Hello everyone, thank you very much for inviting me. I'm very happy to be presenting to you the results of what I can argue is something that I've been working on for about 25 years. It seems like most of my career. My PhD, the latter part of that. And one of the things that I want to say is that one of the things that I've learned over the journey that I've had in examining this area is that some of the things that I have to say about external fixator pin site care, because I suspect a lot of you aren't orthopaedic nurses with an interest in external fixators, have a lot of relevance to other issues in percutaneous wounds and to wound infection generally. So although this is quite a specialist area, I'm hoping that there might be some information that's of use to all of you. So if you look at the picture, those of us that know wounds well would automatically look at that picture and imagine the heat coming out of that leg. And possibly even some smell, and we think about the pain for the patient because we can tell that there's a very significant inflammatory response going on there, and there is a tendency that we would think that those were two infected external fixator pin sites. But what I want to show you is partly that that's not necessarily the case. But before I do that, just to explore the problem a little bit, modern external fixators tend to be circular ones, and actually they have wires rather than pins. And the impact of that is that the number of insertion sites for these wires have increased in comparison to older external fixators. And many patients have something between 18 and 24 actual wire insertion and exertion sites, if you like. So there is a significant issue with the fact that there are a large number of wounds here. The wounds are clearly, because they're percutaneous wounds and they have a foreign body going through them for the duration of treatment, very prone to infection. And remember that treatment is protracted with an external fixator. The minimum is around about 6 weeks. The average is about 12 to 14 weeks, but for some patients this may involve months and occasionally even a year or more with an external fixator in situ. So infections are often repeated. And the problem with external fixator pin sites in comparison to other percutaneous wounds, such as intravascular devices, for example, of course, is that we've got a piece of metal now going through bone. So the risk of infection tracking down into the bone, becoming osteomyelitis and creating terrible problems for the patient in the future are quite severe. So one of the issues around that is that it threatens the success of treatment. Remember that external fixators are used in patients who are at risk of losing a severely damaged leg. So this may well be the last-ditch treatment in an attempt to save a seriously injured limb. Now, one of the problems that we've had with investigating this area and trying to find ways to prevent these actually unsurprisingly common infections is that we don't really have a clear understanding of the difference between infection and something that the literature in this area has been calling reaction for about 25 years. And I wasn't able to identify what that term reaction actually meant, because it was clearly different to infection. And then, of course, the final issue is that when you don't know for sure whether something is infected or not, you're likely to be giving it antibiotics when it may not need it, and we all have to be very wary of that these days. So there are lots of reasons for investigating this problem. Now, when I started to investigate this idea of what a reaction might be, I started to think more about the foreign body reaction, the reaction of tissue to having, in this case, a metal wire through it, but in the case of things like intravascular devices and suprapubic catheters and all of those other things that we have to think about, it would obviously be also a foreign body. And what we have to remember is things like the wound care for these wounds is not aimed at healing, as it is in lots of others. The main process is about preventing infection. And that the tissue around the foreign body, the implant, is doing all sorts of things that may actually complicate that. So, for example, as this shows, the skin doesn't tolerate a free edge very well. Macrophages adhere to, in this case it's a splinter, but that could also be metal or a plastic device. So the whole load of biomaterials and biomedical literature around that is actually very complicated. When you look at that in a bit more detail, you see that percutaneous wound infections are a general problem in all sorts of areas. We've got this issue of a protracted, a long-term defect in the skin, which is bound to make things more prone to infection. And when you look at the literature, there are a few specific factors that it's thought contribute to an increased risk of infection in these wounds. So first of all, there's exposure of subcutaneous tissue, just because we've got this implant keeping the skin open. There are issues around the material that's implanted. Materials behave in various different ways. And, for example, there's lots of work being done on coating skeletal pins in a way that it's hoped would make the infection problems less. And one of the things that very much of interest from a wound care point of view is what's going on at the interface between the implant and the tissue. This is my attempt at an electronic diagram of some kind. But one of the things that we do think happens with a pin going through skin and into bone tissue is that remember that the patient's meant to be mobilising on this limb, so their skin will be moving up and down along the pin as their muscles and skin are moving. And what that tends to cause is something that we call tenting, where it migrates up the pin and gets stuck. So what you actually get is a dead space in that little corner there that acts as a source of infection, because it actually has very poor drainage and poor circulation. And remember that most of these external fixators are on lower legs, where we know that the circulation is poor anyway for all sorts of other reasons. So on further investigation, it's very clear that at the moment there is no validated patient-centred assessment criteria for pin site infection. We don't actually have anything that will tell us that one site is infected and one site isn't. And to be honest with you, my examination of the literature actually tells us that that's true of all wound infections. Because we don't have a gold standard outcome measure, if you like, for infection, that categorically will tell us that a surgical wound, a chronic wound, or even a percutaneous wound is infected, there are serious problems in us being able to identify those that are and that aren't. So, the assessment criteria that's been used the most in this area is by Czech et al., who wrote this in 1993. And I won't read it all out to you, but it talks about things like minor infections being slight redness around the skin, moving up towards having discharge from the pin site, failing to settle with diligent pin site care, moving into major infections where there's what they call severe soft tissue infection involving several pins. And what you can see from this is a description of what, in this case, orthopaedic surgeons think are the criteria that we should use for categorising infections. And when I looked at the literature, actually nobody had gone to talk to any patients about what the issues were and what it felt like when they had an infection, hence the PhD. So, I've done two studies. This was a mixed method approach altogether, which I'll talk you through briefly. The first study was a qualitative study with 16 patients, and I interviewed 16 patients who had experienced pin site infection within the previous few weeks. And my questions were, first of all, what makes patients suspect they have pin site infections? Because I noticed very much that patients were the first people to say to the nurse specialist who was looking after them or their surgeon that they thought they might have an infection. What were their experiences of those symptoms? And how did they differentiate between pin site infection and other wound states? Because I hoped this would give us some information about how we might resolve this issue of not being sure what was what. So what the findings of this part of the study told me was that the patients were telling me that there were 3 different pin site states, if you like. There was a calm pin site that had no signs of inflammation, really, absence or minimal symptoms. They might have some very slight redness, and on some days when they've been walking on their limb quite a lot, they might have a tiny bit of discharge, but there was nothing that was persistent and nothing that really caused them any problems. But then they were describing these 2 other states. They were describing irritated pin sites and infected pin sites, and they were describing them as being quite different. But you'll see here that in both cases they talked about pain, they talked about redness, they talked about discharge, and they talked about swelling. So they both had elements of the inflammatory response going on there, and they also talked about general symptoms. So in the case of infection, they might mention things like they felt unwell, as bit as if they were having the flu, they didn't really feel like eating, and they felt tired. So there was a pattern between these 2, but the patients were very categorically telling me that there was an infected state and there was something that also happened, but it wasn't infection. And they talked about things like it happened if my pins or wires were getting a bit loose, it happened if I'd been overdoing things that day, it happened sometimes for no reason at all, but then it went away again without any problems, and I know that wasn't infection. And they said to me that the way in which they, because a lot of them had more than one infection, the way in which they knew they had an infection is that their limbs suddenly became so painful that they could no longer bear weight on it. And that seemed to be a really central issue in terms of what we might know more about. So the second study was a cross-sectional study with a questionnaire. And I asked, first of all, what was the frequency and severity of the patient-reported symptoms of pin site states? So we looked specifically at the calm state, the irritated state and the infected state. And we asked the same questions of patients who had experienced all 3 states. I wanted to know whether patient responses relating to the presence of and different levels of those symptoms could discriminate between those 3 reported clinical states. And I wanted to know whether there was an underlying structure to the questionnaire, because that was important in terms of the analysis. So the questionnaire asked very specific questions about levels of pain, swelling, redness, discharge, and things like weight-bearing and systemic symptoms in the same way for all 3 of those states. And we used a variety of scales of 1 to 5, where 1 was minimal and 5 was extreme. And some of the questions, like did you have difficulty weight-bearing on the leg, were you able to put the leg down? We asked them if they'd had antibiotics and whether they worked, were yes-no answers. So the sample was 165 adults who all had lower limb external fixators of some kind across 7 sites, 7 acute NHS trusts, where I had a nurse specialist in each of those trusts who gave questionnaires to patients, and there was a box in the outpatients department where they could return them, or they could return them by post to me. And you'll see that the numbers across the 7 sites are quite different, and that's sometimes to do with the timing at which point that hospital joined the study, and also because some units do lots of external fixator work. The largest in the country is funnily enough, in Yorkshire somewhere, and they do around about 300 a year. So that the numbers in some places are much smaller than that. So if you think about it in comparison to other kinds of orthopaedic surgery, those numbers are actually quite small generically. So the findings, we analysed the data using one-way ANOVAs and Cochrane's Qs. So these are the things that are starting to give us some ideas about where this is going now. So looking at redness, swelling, pain, discharge, heat and burning, shiny skin and smell, we found that all of those were greatest when the patient had an infected pin site, but that they were less in irritated pin sites, and they were not present at all or very slight in calm pin sites. And that redness, swelling and pain demonstrated the greatest variability in the scores between the 3 states. So That's kind of starting to indicate that, as we thought, redness, swelling and pain are quite significant indicators, but it's the level of that redness, swelling and pain that seems to indicate the difference between irritation and infection. We asked them about itchiness, and that was greater in irritated pin sites than it was in infected pin sites. But when we asked them about difficulty or pain using the leg or weight bearing, that was by far the greatest with infection. Nausea, vomiting, feeling unwell, feeling feverish and shivering were largely features of infection, but not all patients who had an infection experienced those symptoms. And we also asked them about disturbed sleep, and actually that's a bit that's not going to provide us with that much help, because if you think about what it must be like to try and sleep with a massive piece of metal encircling your leg and about 18 wires going through your leg, you're going to have problems with that, whether you've got an infection or not. So I don't believe that that actually provides us with a lot of useful information, but that's certainly something that needs further research in itself anyway. So the principal components analysis, what that indicated was the presence of two components. So within the questions in the questionnaire, there were two components that were different for infection and irritation. Pain, redness, shiny skin and heat and burning were all features of the first component. So if you think about it, that's consistent with the classic inflammatory symptoms, but itchiness, dry, flaky skin and smell were features of the second. And what became evident on further investigation of the literature, those appear to some degree to be consistent with symptoms that relate to contact dermatitis. And it was helpful that one of my PhD supervisors has a dermatology background, so that kind of helped me to understand that side of things in a lot more detail. So just to provide you with a little bit of background information back, because it helps to elucidate this a bit more. Contact dermatitis is also known as contact eczema. It's an inflammatory skin condition, and that's usually related to a reaction caused by a response to an external agent that acts as either an irritant or an allergen, and that can be allergic or irritant. And the acute symptoms of both irritant and allergic dermatitis are similar, and they include things like blistering, redness, itching, swelling, and small papules in the skin and exudation. And actually, I've seen examples of this in patients with external fixators, so I'm pretty sure that that is something that's going on, and that some patients have contact dermatitis rather than infection, but that doesn't mean to say that they don't necessarily have contact dermatitis and an infection going on at the same time, so there's still a question of that going on. If you think about the possible irritants for patients with external fixators, so first of all, they've got the presence of metal in the tissue as a foreign body. Now, I'm ashamed to have to say that I had to contact an orthopaedic surgeon to ask him to confirm for me what the metal was that the pins were made of, because I hadn't really thought about it in that much detail before, and I'm told that they're made of stainless steel. What I didn't know until I investigated it is that stainless steel contains nickel, and about 10% of the population are allergic to nickel. And there's very little in the orthopaedic literature that talks about the potential for that to cause problems. I have a very significant nickel allergy, so I would be well, maybe I wouldn't be that interested to know what would happen to my skin if I had 18 wires going through it that were left there for 12 to 14 weeks. We also use the guidance for pin site care at the moment suggests that chlorhexidine, gluconate and alcohol solutions are the best. They're both big culprits in causing irritation to skin and contact dermatitis. The other issue to remember is that the guidelines also say that patients should shower once a week when they have an external fixation in situ. There may be some in this room who shower twice a day, so I'm sure that you can imagine that that's very difficult for the majority of people. And with that many wires going through your skin and a big metal frame on the outside of it, carrying out normal skin care for patients, even getting anywhere near their skin with moisturiser, for example, is virtually impossible for them. So the skin's ability to shed dead cells and maintain a healthy state is quite significantly affected. And when I looked into metal allergy, it became evident that there are lots of issues with that the orthopaedic care community hasn't really considered at all. So that's, in a nutshell, the findings. In terms of implications for practice, this leaves us with a bit more knowledge about what might be going on here, but some more work to do from that point of view. So first off, we know that infection definitely needs to be diagnosed using patient-reported signs and symptoms, that the existing criteria that we've got available up to now don't really do that because it's not focused on patient-based data. That patients need verbal and written information about what they're looking for, and that their perceptions of the presence of infection need to be taken seriously. It's very apparent that they're the ones that know what the problem is, how it is, and whether it's infection or not. And the whole issue of dermatitis for these patients needs further very careful consideration. I do know that there's a study going on in Hull at the moment that's looking at using moisturisers with patients who have external fixators in situ. So I've taken the liberty of proposing an assessment tool. I've called it Rapido because I'm learning Italian, and RP, D and O stand for redness, pain, discharge and other. I'm talking to my orthopaedic colleagues about the possibility of trying this out in practice to see if it works in terms of finding out whether patients' pin sites are calm, irritated or infected, based on their levels of redness, pain, discharge and other symptoms, so that we can start to get some ideas of whether this is actually going to help us to identify pin sites that are affected or not, both from a practice point of view, because it's important, but also this now starts to generate some possibilities in terms of measuring infection as an outcome in potential clinical trials of wound care measures to prevent infection. But there's still quite a lot of work to do on that, because we now have a bit of an idea of its content validity, but the other bits of validity still need to be explored. So in terms of what next, we need to know whether that works. If it would work, how would it work? What would we need to do in order to make such a tool available and easy to use for patients who mostly look after their pin sites for months on end on their own at home? Could we use it as an outcome measure? And what are we really going to do about the dermatitis? What really is causing it? And what are the management issues that we need to consider from that point of view? So, thank you.